Hi, my name is Crystal, MSc student at UCL, and today we're going to be listening to an interview by a former MSc student, now Consultant General Surgeon, Mr. Jonathan Knowles. We'll hear of his journey through the MSc course and how his life so far has been as a Consultant General Surgeon. I hope you enjoy our interview. Thanks.
There are a number of things, but I think one of the main things is the change in pace from doing clinical work. So you've got a bit more time to reflect on what you're doing. It's much more intellectual and less practical. So I think some of the most enjoyable bits were the time sitting around with your colleagues who are also doing MSCs, discussing your projects, coming up with ideas, and looking at ways to actually further your research, because it's completely different from what you did clinically as a SHO and house officer for me. Oh, patience. Because otherwise I'd be saying bottoms and that would be very strange, but it's definitely patience. Because most patients are incredibly lovely to work with. The patients who come in with terrible problems, bad cancer problems, bad irritable bad inflammatory bowel disease, and in general they are incredibly grateful, really lovely to work with, and that's far and away the best bit. Firstly, I didn't think it was a big surprise. One of the things that came out of the work that I did and the theory that I learned from my MSc is cancers are so complicated, and cancer metastasis, cancer growth is such a complicated process that targeting single agents isn't going to be effective. And really the kind of work that I'm looking at, the work with VEGF and things, it's not likely to be single agents that are going to make a difference. And this idea of targeted therapy, where you're having maybe 3 or 4 targeted agents based on the genetic profile of individual tumours, is much more likely to be successful. The difficulty with that is that kind of work is going to be very difficult to trial, because trials really need a single agent and they need an outcome, and they're nearly always in cancer done on patients who have advanced disease with short life expectancies in small numbers. So there are lots of problems with getting to that goal, but I don't see there being much hope for individual agents like that working against single targets. I'm sure that they will. I think they'll be part of an arsenal. Okay. So I think you'll have anti-angiogenic, you'll have anti-desmoplastic, like ET1 was, and you're going to have anti-epithelial kind of drugs. So you're going to get a mixture of anti-proliferation, anti-stromal, anti-angiogenesis, and I think then we'll see effects. I don't think so. I mean, in theory, it can be obviously used for anything, but one of the differences with colorectal, and one of the reasons that the patients usually do quite well, is you've got so much tissue redundancy that if you lose nearly all of your colon, you can still have a pretty good quality of life. So if you're making tissue to replace tissue, it's really got to be because it's essential. So in colorectal, it's unlikely. The number of patients that we have who have such little intestine that you would need to regenerate tissue for them are so small that I don't actually see it being useful. Well, certainly not until all of the other fields have had their slice proven its work.
Okay. Well, thank you very much for your time.
It's a pleasure.